This is going to be a very quick section on action potential. Yeah, and depolarization, really, shall we consider that? So I've actually cleaned that now, so I have a bit more space there. Some cells, like cardiac cells, like because I'm doing cardiology, cardiac cells, three properties, shall I say properties? Properties is include automaticity, contractibility, excitability, and the ability to propagate an impulse that has been formed. So this obviously helps the cell to then do what it's supposed to do, such as contracting. So in terms of cardiac cells, so if we were to remember how impulse is generated in cardiac cells, we have to begin from the chambers themselves. If we go back to the chambers of the heart, we'll remember in the first section that I gave, I talked about the SA node, which is found in the right atrium, just next to, well, in the right atrium really. And the SA node is an impulse generator. And it's called the pacemaker of the heart. The natural pacemaker, shall we say, pacemaker. The natural pacemaker. So when the SA node generates that impulse, that impulse travels down into the AV node. The AV node is found in it's called the atrioventricular node, meaning that it lies between the between the atria, both atria and the ventricles. So if we're to think of the chambers, I should have really drawn it like this to make my life a bit easier. So if we're to think of the chambers as this is the atrium. Let's start up right. This is the right atrium and the right ventricle. This is the left atrium and the left ventricle, more or less. So the impulse travels down from the SA node into the AV node, which lies there, and separates the atrium and ventricle. We must remember that we have an annulus fiber there that really forces all the impulse to travel down using this pathway. So while atria contraction obviously then forces, causes the left atria to contract as well, impulse that causes ventricular contraction travels down into the AV node. So this is our AV node. And this is the annulus fibers, which ensures that the impulse comes in through the AV node. So from the AV node, the impulse will then travel down his bungle. Down his bungle. And then divide into a right bundle branch and a left bundle branch. The right bundle branch will then form the Purkinje fibers, which really are specialized muscle fibers that then connect the impulse or the electrical mechanism of the heart into the actual cardiomyocyte. So these are the Purkinje fibers of the right. So this is the Purkinje fibers, Purkinje fibers of the right bundle branch. So this is the right bundle branch. The left bundle branch goes into the left ventricle, and it then divides into the posterior fascicle and the anterior fascicle. So we'll have the left posterior fascicle and the left anterior fascicle. So really the difference is that on the right we'll have the right bundle branch does not divide. It just forms, it just comes into the whole ventricle, but then it just gives on the Purkinje fibers. But the left bundle branch, so this is the left bundle branch, will form the anterior and posterior fascicles that then function to depolarize the left ventricle. So in terms of depolarization itself, impulse is generated from the SA node, and it travels down that system which I've just drawn out. So the cardiac cells themselves have a resting membrane of minus 90 millivolts. So this is minus 90 millivolts. That's their resting membrane. And when we say resting, we mean nothing is happening. The cell has, resting. The internal cell, it has a high concentration of potassium, and the outer cell has sodium and calcium. They are found on the outside. So this is a resting cell that's not doing anything, that's just there. So its resting potential is minus 90. So at minus 90, this is usually called phase 4 of the depolarization. So from phase 4, this is a happy cell that's just sitting there, minding its own business, really, shall we say. Perhaps up to 20, minding its own business at phase 4. I don't know, like minus 50 or something. I just said minus 45, not that way. So this is a cell that's just resting there. So when impulse is generated from the SA node, as in catecholamines are released, this is based on the release of catecholamines, again based on on sympathetic nervous stimulation. So the secretion of catecholamines causes the impulse to be generated, and when impulse is first generated, sodium channels will open there. So we'll have sodium channels opening, and as they open, they cause a sharp depolarization of the cell. And when that sharp depolarization happens, the cell will obviously move from, because sodium ions are positive, the cell will move from a negative state to a more positive, towards a more positive state. in order for it to become excitable and for it to start doing what it's supposed to do, contract. So it will move towards a more positive state. And really, when sodium channels open, we think of them as being the fast acting sodium channels in terms of the impulse they generate, spikes up very quickly and immediately goes down like that. So they are the fast sodium channels. They're the first ones to open. And as they open, that depolarization phase, that fast, quick happening depolarization, is called phase 0. So this is phase 0. So during that quick depolarization, when we reach, I can't remember what it is, when we reach minus, I think it's minus 20 or is it minus 40, the calcium channels will start to open as well. These are the long-acting calcium channels to let calcium into the cell. However, phase 0 is much more dependent on the movement of sodium from the outer surface of the cell into the intracellular compartment. And as that happens, the cell will naturally want to normalize that effect of sodium coming in and making the cell more positive. It will naturally want to correct that. And it does so by opening the potassium ion channels. And let's remember that potassium is normally inside the cell, and potassium is also positive. So when the cell opens the potassium channel, we get a slight repolarization. It's not enormous, it's just a tiny effect which we see as a sharp downwards turn, but it's not really enough to correct and bring the cell back to its resting membrane potential. So that there will be called phase 1. I'll just write the number in fact. And phase 1 arises from potassium channel is opening and causing the efflux of potassium from the cell. And as that is happening, the cell obviously is still in the phase of depolarizing to reach its absolute refractory, so that it can then contract, being a cardiac myocyte. And then we reach the L-type calcium channels then actually open, and this is called phase 2, the opening of the calcium channel. So this is the most important phase, I would say. So this is calcium influx. So as calcium comes into the cell, again, let's remember calcium is another positively charged ion. It stops the correction that is happening due to the efflux of potassium, and it causes the stabilization of that positivity to continue, and we reach a plateau phase. So calcium is really the plateau phase, as in it's a slow process, it's a slow influx of ion, of calcium. However, what it does is that it maintains that state of positivity. It allows that impulse that has been generated to remain there and not be lost, so that that impulse can then travel down into all of the cells, including the ventricles, to allow the cell to contract. So then once we have calcium coming in, if we were to go back actually into the cell and look at this at a cellular level, we will find this diagram, which I have already drawn there. So we will find that as calcium comes in, it causes what we call calcium dependent calcium increase. In the sense that when calcium comes into the cell, it causes the sarcoplasmic reticulum to open its own channel. Sarcoplasmic is a calcium-rich store. So when calcium comes into the cell, it causes the sarcoplasmic reticulum to open up and release even more calcium into the cell. And this calcium, which comes from the sarcoplasmic reticulum, is the calcium that we actually use for contraction. So we get calcium, increased calcium into the cell, intracellular. And this calcium becomes available for muscle contraction. And if we were to go back and look at it again and look at this from a cellular level, we will remember that muscle contraction has an actin filament, and actin has troponins. It has troponin I, troponin C, and troponin M. So this is actin. And it also has myosin, which is obviously tethered to titin, which is the elastic protein that allows for elongation and contraction, i.e. contraction. So myosin has heads that want to bind onto the actin filament. So as calcium comes into the cell, it causes the troponin, the inhibitory aspect of troponin is released, and calcium then binds into troponin C. And in binding troponin C, it causes a conformational change of the whole protein, which then exposes the myosin binding sites on the actin and allows for the interaction of actin and myosin, which really is contraction. So this intracellular calcium that's coming from the sarcoplasmic reticulum is this calcium that we use for contraction. So as that calcium happens, this cell is now in absolute refractory, which basically means that it can no longer be depolarized, even if any more impulse is generated or tries to come in. The cell can no longer be depolarized because this is a cell that is now at work undergoing contraction. And then once that has happened, even more potassium, and during the plateau phase, actually I must say that the outflow of potassium is actually directly proportional to the inflow of calcium, which is why this is more of a stable plateau phase. However, repolarization then happens, and when repolarization happens, it means that even more potassium is being lost, and and calcium as well. So this is efflux, and calcium is decreasing because obviously we have used some of the calcium, so calcium starts to decrease as well. So then we enter phase 3, which is the repolarization of the membrane. And relatively refractory. So at times cells will become hyperpolarized if this continues to happen, but normally the cell will then really, like this will be hyperpolarization there, hyper-repolarization if this continues forever. But normally the cell will then go back to its resting membrane potential, which is phase 4. However, when we reach phase 4, we must remember that we have lost a lot of potassium. We have a lot of so in phase 4, the cell is potassium depleted because the cell has been trying to correct the positivity that has been caused by sodium influx and calcium influx. So it's potassium depleted, however it has a lot of sodium. So it's very rich in sodium, which means that although we're back at -90 for a cardiomyocyte, we are not really at a state where we can say that everything is back to normal. The cell still hasn't returned to its normal intracellular concentration, as in its normal hemostasis of having more potassium inside and more sodium and calcium on the outside. So then the cell will then normally use the sodium potassium exchanger, which is inserted onto the cell membrane, and all it does really is pump out sodium and pump in potassium from the outside. It also will use a calcium antiporter as well, but a calcium antiporter is usually an ATP dependent. So really these channels, as in these pores, are inserted onto the membrane, and all they do is they correct the ions and move sodium and calcium out of the cell, bring back potassium, and the cell then returns back to its resting membrane potential. And I must say, it's corrected ion concentrations with the correct ions inside and outside. And then in phase 4, then the cell is then ready again for, if another action potential comes in, the cell will then depolarize as it happens. So this is depolarization. So and we really need to mention that in phase 3, this is called relative refractory. And relative refractory just means that if another impulse was to arrive, the cell will be able to depolarize. So this is how depolarization actually happens. So the really importance of depolarization, or how we see it visually in terms of knowing that it has happened, is really through ECGs. And if we were to just go back to a normal ECG, really, a normal ECG will have a baseline, and then we'll see atrial depolarization, and then the starting of ventricular depolarization, and the actual ventricular depolarization and repolarization. So in terms of naming the ECG components, we'll have a P wave, A P wave is atria contraction following the impulse generation from the SA node. And then we'll have, as atrial depolarization polarizes, we'll have the starting of the impulse as it's traveling to the AV node. And then reaching, okay, this is Q, R, S, T. So we'll have that impulse traveling to the ventricles, remember, from the AV node, from the SA node to the AV node to depolarize the ventricles. And then we'll have R, S as ventricular depolarization, and we normally just name it the QRS complex. Which really is ventricular depolarization. And T is repolarization, to return to the resting membrane potential. And obviously if another impulse comes in again, we will have the same thing happening, P, and then forming the QRS complex over and over. So this is just the normal ECG with, and this line is just called the baseline, as in where everything is read from. And in terms of ECG, whenever there is a P wave, then we always say it's a sinus rhythm, because we know that the depolarization has arrived from the atrium based on that the P wave has been formed. So it is a sinus rhythm. In the next session, I'll actually go into ECG properly in terms of looking at the ECG leads. Or I could actually quickly do the leads here, so that then when I do ECG, I'm just specifically just doing pathologies and the other bits, such as how to count boxes in order to work out the heart rate. Usually it's boxes divided by into 300 in order to get the heart rate, but then I'll have to do that. ECG is a much more big topic, and it really needs to be done on its own. However, leads placement, for ECG leads, we have AVL, which is placed on the left arm, then AVR, again right arm, and then AVF will go on the foot, and then these are the limb leads. Well, those were the limb leads. And then our chest leads are normally placed, our chest leads are V1, V2, V3, V4, V5, and V6. They're placed mostly on the left side of the chest, directly above the heart. So V1 and V2, their placement is more on the sternum. V6 is more mid axilla. V4 is mid sternum. So V5 is placed between V4 and V6, and V3 is placed between V2 and V4. But what they actually look at is V1 and V2 are what we call the septal leads, based on where they are. So they look at the septum of the heart. V3 and V4 are the anterior leads, as in they look at the anterior wall of the left ventricle. Remember, the ECG mainly looks at the left ventricle, and we know that the left ventricle is really a reflection as well of what's happening in the entire heart, because the heart works as one thing. And then V5 and V6 are the lateral leads. So they will look at the lateral and posterior aspects of the heart. And AVF, like the limb leads such as AVF, lead 1 and lead 2, are the inferior leads. They are looking at the inferior wall of the heart. And then V3 is the posterior lead, and it looks at the posterior wall of the heart. So this is all I wanted to do in terms of the leads, so that when I do pathology I don't have to go back and do the leads as well. And again, if we're really just to quickly do the blood vessels, the septal leads will be supplied by the left anterior descending. So this is the left coronary artery. The anterior leads will be supplied again by the left coronary artery. The lateral leads, again, left coronary artery. The posterior leads, again, is the right coronary artery. And the inferior as well is both the right coronary artery and the left coronary artery. However, if we're to look at the say if we had problems with the sign with the SA node, which is where the right coronary artery, or the conduction system in general, shall we just say conduction system? The conduction system of the heart is supplied by the right coronary artery. It gives off branches to the SA node and gives off branches to the AV node. So yeah, so that's the other important thing about ECG, to then match them back with the coronary arteries that supply them. For example, say if someone, we've been learning about acute coronary syndrome, if someone had an ST elevation in leads V3 and V4, so if their leads V3 and V4 looked like an ST elevation, then we'll definitely know that this person is having an anterior myocardial infarction, and we'll know that the pathology is actually in the left coronary artery. So if we're to thrombolize this person, we'll know exactly that we need to go into the left coronary artery, or even if we're to do a bypass, we will know that it is in the left coronary artery. So really the point of the ECG is to show us exactly the electrical activity of the heart, and also to show us pathology of where the pathology is in terms of the coronary arteries. And I'm going to end this now so that I don't take up too much space on my memory card.